This next section is the last installment on medicinal chemistry of drugs acting on autonomic nervous system. This section we will have the beta receptor blockers, or the drugs that commonly ends with olol. The actions of our beta blockers commonly affect our heart and our lungs. Once our beta blockers block our heart, it will cause decreased heart rate, decreased force of contraction, and decreased rate of our AV conduction. But there are also pronounced side effects that is associated with beta blocker use. These are bradycardia, lethargy, GI disturbances, CHF or congestive heart failure, sudden decrease of blood pressure, and depression. Now let's start with the structure-activity relationship of our beta blockers. So the first beta blocker started or was reported in the year 1958 by Powell and Slater. It was discovered with this structure or this chemical name dicloisoproterenol. This one was the first line treatment for glaucoma. It is also widely employed as antihypertensive. This is the structure of our dichloroisoproterenol. This originates from isoproterenol. Dichloroisoproterenol differ structurally from isoproterenol in that the agonists directing 3,4-dihydroxy groups have been replaced by 2 chloro groups, which is the reason why it is synthesized therapeutically as a useful beta blocker. Now moving forward, these are now the drugs that antagonize our beta receptors. The prototype for this drug class is our propranolol with the brand name Inderal. This propranolol has an aryl oxypropanol amine structure that is derived from modifications of the earlier antagonist that I have mentioned, the dichloroisoproterenol. So the pharmacophore of our propranolol is aryl oxypropanolamine. It is derived from dichloroisoproterenol. Generally, an aryl ethyl amino or similar large hydrophobic group without phenolic hydroxyl is required for antagonistic activity, non-selective to both beta 1 and beta 2. And another example is timolol, nadolol, and cartilol. For your activity on this section, I want you to look for the structure of timolol, nadolol, and cartilol and compare it with our propranolol's pharmacophore. Please take note that substitutions para to the phenoxy position increase the relative beta-1 selectivity of these agents. An example is our selective metoprolol, atenolol, and acebutolol. So you compare and look and compare for the structures of our beta-1 selective versus the previously mentioned non-selective beta receptor antagonist. Another example is pindolol, which has a significant agonistic activity comparable with cartilol at beta receptors and are more appropriately partial agonists than antagonists. Our labetalol and carvedilol has an S isomer of the said pharmacophore, and that caused the significant beta-1 receptor antagonist activity in addition to beta blocking actions. So beta 1 receptor antagonists are used to manage several diverse conditions such as hypertension, post-MI, cardiac arrhythmias, angina, congestive heart failure, stage fright, hand tremors, and glaucoma. Their use in hypertension has been largely supplanted by more effective agents. However, they have been shown to be very effective in preventing a second MI. It also slows down progression of CHF and can decrease the incidence of stable angina. Now let's discuss in detail our non-selective beta blocker, the first generation propanolol, the prototype of our beta blocker. So propanolol, again, it has a pharmacophore aryl oxypropanolamine that blocks both beta 1 and beta 2 because it has equal affinity to beta 1 and beta 2. It does not block our alpha receptor and it is lipophilic, so it can penetrate our central nervous system. So it is also useful to treat anxiety and for under investigation treatment for schizophrenia, alcohol withdrawal syndrome, and aggressive behavior. Now, with the second class or the more selective antagonist, the beta selective blockers, or the second generation. These are the mentioned metoprolol, pindolol, atenolol, carvedilol, and among others. So they lack of a blocking effect on our beta 2 receptors located in our bronchi, which would make our beta 1 blocker safe for use for bronchial asthma. The absence of blockade on the vascular beta 2 receptors can mediate vasodilation. So these are the examples of our beta 1 selective blockers. Now moving forward to our beta 2 blockers with alpha 1 antagonist activity, the third generation. So we have labetalol, which is a derivative of phenylethanolamine. That is why it has an alpha 1 antagonistic activity. It's more potent beta blocker, but it has alpha blocker activity as well. A mixture of 4 isomer which is used clinically in treating hypertension, and also it can produce vasodilation. The beta receptor blocking effect prevent the reflex tachycardia usually associated with vasodilation. And labetalol is well absorbed because of its structure. The next one, our last example, is carvedilol. So carvedilol is a beta blocker that also possesses alpha 1 blocking activity. Its beta blocking activity is 10 to 100-fold of its alpha blocking activity, and it possesses antioxidant activity and an anti-proliferative effect on vascular smooth muscles. It has a neuroprotective effect and the ability to provide cardiovascular organ protection. It is useful in treating hypertension and congestive heart failure. So this is the last part of our journey on medicinal chemistry of drugs in autonomic nervous system. Thank you so much for listening.